Diagnosis of hip impingement: pain is the initial symptom. Usually pain is in the front or side of the hip, but can also be in the back or buttock area and radiate down the leg. Pain is usually worse with bending type positions, sitting in a deep chair, deep flexion rotations of the hip, bringing the knee up deep into the chest as well as towards the other side is usually a painful position. Sitting in a car for prolonged periods, getting in and out of a car, getting up from a seat, all can be quite painful with hip impingement. Generally the pain is a deep dull ache, but with these certain extremes of motions can be quite sharp and stabbing. And there can be other mechanical symptoms, locking and catching of the hip as the joint becomes inflamed and as tissues do not function as they normally should do. On exam with hip impingement, we look at how a person walks initially, if there's a significant limp, if there's restriction in motion during gait, during walking. We then look at the motion of the hip and see how it is restricted. In particular, how the motion of bringing the knee up deep into the chest and in towards the opposite side, how that motion feels and how it is restricted is important. We then look at tenderness around the hip, strength of tissues, particularly lifting the leg and lifting the leg to the side, lifting the leg forward and to the side. Alignment of the back and the lower extremity and pelvis and so on is also important. X-rays are very helpful, first to tell us grossly how the cartilage looks, if the joint space is narrowed, if there is significant arthritic change and loss of cartilage. Then it helps us determine the architecture and shape of the hip. We look for deviations in the orientation and coverage of the hip socket. We look for deviations in the shape of the head-neck junction, where the femoral head becomes the femoral neck, and how that is shaped and if it is symmetric in the way it should be. These give us clues if this is indeed a potential problem for a patient. MRI is a very helpful test as well. An MRI can have important information on the soft tissue structures around the hip, particularly the labrum. We look at the labrum, how it attaches to the bone and if it is of normal shape. Generally, an MRI with contrast is much more helpful, much more resolution, and much better resolution, and look at tissues. We look at the signal of the bone, see if there's increased fluid in the bone of the socket or femoral head. We then look for cysts around the femoral head and neck and hip socket, amount of fluid in the joint, the look of the soft tissue of the joint capsule, and then surrounding tissues, the tendon, psoas tendon, and so on, to look to see if they look normal in terms of thickness and fluid levels and so on. And it gives us a fairly good idea, better than any other test currently, of the shape of the articular cartilage. This is one of the most important things to determine with a patient, because once cartilage damage has progressed too far, joint preserving surgery is no longer a good option. And so looking at the articular cartilage of the hip socket and femoral head is critical to decide if this is a problem that joint preservation surgery can be of benefit.